I've not presented it in a long time. Do you want it? Do you know how to get to? Oh, no, never mind. I see.
Okay.
I'm slightly more tech savvy than you, so I'm just kidding. Okay, so the topic I decided to research on was emergency resuscitative thoracotomy. It's a really big word. It's really cool. Let me get into it. I decided to research. Oh, let me kind of talk about what I'm going to present on first because there's a lot. I'm going to kind of introduce my research question, then give you a look into what emergency resuscitative thoracotomy looks like, settings and indications for that, and then an assessment of the outcomes for the procedure. So my research question was, with giving consideration to the goal of an emergency resuscitative thoracotomy, is it truly necessary to perform this procedure, and do the possible complications outweigh the effectiveness of the procedure? The article I chose to present on was written by a group of professors from the University of Milan in Italy. They were seeking to understand over time with this procedure, how effective is it? What is the rate of outcome? And is this necessary, and what are the alternatives? I actually do want to know, I was able to actually contact one of the professors who put together this paper, and we had an email exchange. He was amazing. He gave me a lot of resources, more than I could include. So shout out to Professor Aseni. The way they conducted this research was they went through a series of databases with a very specific research criteria that I didn't understand. But what they were trying to determine was over time, from a period of 55 years from 1975 to, or 45 years, 1975 to 2020, to take a look at these, when these procedures were performed, who they were performed on, and if those procedures were successful. They kind of divided it into two main categories, penetrating trauma patients and blunt trauma patients. The difference therein is that penetrating, for example, if you were to be stabbed, that would be a penetrating trauma. A blunt force trauma would be impact to the chest. And so you can see that they took number of survivors, and then the different patients they proceeded or did the procedure on, and then what the rate of outcome was. At the end, you'll see they included neuro impairment, which is when your heart is not working, it's not providing blood to the brain. And when your brain tissue dies, you don't get that back. So that would be considered neuro impairment. And so they, any kind of deficit that you had following procedure, regardless of how great or little it was, it would be considered neuro impairment. Okay, so let's get into it. Emergency resuscitative thoracotomy, ERT, an emergency implying that it needs to be done right away. Resuscitation is where you are bringing someone basically back to life. You're getting their body restarted again. And then thoracotomy, that means to open up the thorax. So this is an open thorax procedure. What it's being performed on is the cardiac box. It's this area of your chest. It includes your heart, which is surrounded in a thin membrane called the pericardium. And then it also includes your ascending and descending aorta and your right and left pulmonary arteries. So these are your major cardiac structures. Obviously, any damage done to the cardiac box is very, very severe. For example, the closer you bleed internally to your heart, the more severe that's going to be. So this is a procedure that needs to be performed very quickly. You need direct access to the heart as rapidly as possible. There are two main points of access for emergency thoracotomy. The first one is a left anterolateral incision. That would take place in the fifth intercostal space. So right about there on me. It's called the first one is, oh, I switched those up. The first one's a small incision. So you'll see up there, it's right on the side of the heart, gives you direct access. The second one is called a bilateral anterior incision. This one's a lot more drastic. Basically, they're cutting from the fifth intercostal space on the left all the way to the right. They're taking retractors and they're pulling open your chest. So very open heart, obviously very traumatic for the body. And this would also involve a sternotomy, which is cutting the sternum straight up. Again, very traumatic. If you're in a situation in which you need a thoracotomy to begin with, you're already in critical condition. So then you have to think about, when you do this procedure, is your body going to heal if you get resuscitation back? So, and then you hold that open with retractors, as you can see. And then the next slide, it's kind of, oh, is the next slide? Nope, okay. There, I have a picture of it. It's a little graphic, but we're science majors. So when you're doing this procedure, they broke it down into indications and contraindications, or selective indications. Basically, so an indication is something that tells you should do this procedure. A contraindication would be things that tell you not to do the procedure. Obviously, if you're in critical enough condition, there's not a lot telling you to not do the procedure. If it's going to save your life, you're going to do it. So some of the major indications, I'll just kind of go through these really quickly. Having a systolic blood pressure of 70 or less, meaning you're in hemodynamic shock. Your body's not compensating. If you're not responsive to fluids, which would increase your blood pressure, if your blood pressure continues to stay low, that would be an indication to undergo this procedure. Cardiac tamponade is a big one. The pericardium, like I said, the membrane that surrounds the heart, that can become filled with fluids. So that can be blood or bodily fluids. If you were to put like a balloon into a bottle of water and try to blow it up, it wouldn't work. It wouldn't move. In the same way, if your heart becomes surrounded with fluid, it's not going to pump and it's not going to do its job. Other things would include an air embolus, which can come from a lot of things, but that would basically be a bubble of air in your vessels. A tracheobronchial disruption would basically be any shift within any of the vessels, including your trachea. Another really major one is witness cardiac arrest with definite signs of life, meaning if your patient has gone into cardiac arrest, but within a 15-minute time frame prior, they were showing any kinds of signs of life, this would be an indication to do this procedure because you might have a chance to get them back. And then finally, penetrating chest trauma in the cardiac box. Again, my example was if you were stabbed anywhere in this area, if that was puncturing your heart or any of the major vessels, this would give you a chance to get them back. And then some of the more selective ones, and this is kind of in a ascending or descending order from more acceptable to least acceptable. Cardiac box injury with signs of life. Any hemodynamic instability or stability. This would be an assessment to where you look at how bad the trauma is in the cardiac box and determine, do I want to do this procedure to save my patient? An exsanguating abdominal vascular injury is basically any injury internally where blood is pouring out. You would determine, okay, based on my patient's condition, are they at a point where if I open their chest right now, can I seal up that wound and save them? That would include aortic cross clamping, or are they kind of out of that window of being able to save? Crushing chest trauma, the reason why this is kind of a more lower priority patient is because if your chest is crushed and you're in cardiac arrest, you're already not, if CPR wasn't effective because your chest is crushed, it's probably not going to be effective to open up the chest and proceed with any procedures. So those kind of last two go hand in hand. Okay, the researchers put together this really cool chart. Again, I'm not going to run through the whole thing because it's very long. I do want to note that there are two major categories they broke it up into. So this is, this is for considering ERDT, which is an emergency department resuscitative thoracotomy in trauma patients. They broke this up into two categories: cardiac arrest with no signs of life and cardiac arrest with signs of life. If a patient has had cardiac arrest and they look closer to being dead, you would evaluate cardiac activity. This could be a patient, for example, with PEA, which is pulseless electrical activity. So their body is not showing signs of life, but their heart still has some electrical activity. On the flip side, and this would be a more likely patient to survive this procedure, would be cardiac arrest with signs of life. You've seen them moving, it's been a time frame where you know, like, they just died, you can save that brain tissue. And then it kind of breaks it down into the different traumas. The middle one is called an extrathoracic massive hemorrhage. That differs from the two in that it's specifically hemorrhage in the thoracic cavity. Okay, this is really cool. I really like this. People who saw me working on this presentation got scared every time they looked at my laptop screen when I was looking at photos for this. But this is basically the clamshell. This is the lateral incision. You can see the heart. This is the pericardium that surrounds it. This notch right here is the cardiac notch. It's in the left lung. It's where the heart sits. Once this, so that's the ERDT, right? You've opened up the chest. You have access to the heart and to the, I love Savannah's face back there. You've opened up, you have access to the heart Here are some things that you can do that would be follow-up procedures. The first one would be a cardiac massage. Has anyone ever done CPR or trained for it? Yeah, cool. So when you're doing CPR, you're pushing on the chest. What that's doing is causing the heart to pump blood specifically to the brain. If your patient has any kind of chest trauma that prevents you from doing CPR, when you've got the patient in this procedure, this would be a manual procedure where you take your hand and you just squeeze the heart in the rhythm of it needing to pump blood to the brain. Super cool. I thought about including a video, but I didn't want to do that to you guys at 8 o'clock in the morning. The second procedure you could do is an aortic cross clamping. This would be in the event of an air embolism in the veins or the vessels. This would be to cut off access for this air embolism into the heart, because once the air embolism gets into the heart, it's really, really hard to reverse the effects of that. The fourth major procedure would be pericardiocentesis for cardiac tamponade. If your heart is full of fluid on the outside, this would be a drainage of that fluid to allow it to continue beating. And finally, control of intrathoracic hemorrhage, which also goes hand in hand with the aortic cross clamping in that you're stopping any intrathoracic bleeding. So that's pretty cool. Again, this is a really traumatic procedure, right? You saw your heart's open. Your heart is not supposed to be outside of your body. So the researchers kind of were looking at these outcomes and determining when should you do this, right? They noted that this was going to be fetal care, meaning that this is providing care for a patient where they probably don't have a good chance of living. So then it comes down to the patient. If they have a DNR, you wouldn't obviously do this procedure. They're kind of out of that window. If you think you have a chance and you're a doctor and you're like really confident in your skills, this would be another case in which you determine, do I want to do this for this patient? Because obviously once you've got them back, you've got ROSC, which is return of spontaneous circulation, their body still has to heal. If their body was weak enough or damaged enough to go into cardiac arrest in the first place, what is the chance of them being able to heal from this procedure? They noted that this would be most appropriate for patients who are in extremis, which means to the point of death. If your patient is just having like some kind of arrhythmia, obviously you wouldn't do this. It would just be a lot of something they don't need, making a mountain of a molehill. They did note that if you have a patient with penetrating chest trauma, it's more successful and appropriate to perform this procedure on them rather than if they have blunt trauma. Okay. So they took an analysis of all of their research, all these articles they read, and looked at the outcomes. They took averages of each scenario. Of their research, 7,236 patients underwent ERT for various reasons. Of these patients, about 7.6 of them survived. Of those 7.6 survivors, 1.6 of them were blunt force trauma patients. And the penetrating trauma took up 9.9%, so about 10%. One good outcome, and this is not super common for cardiac procedures in emergency settings, about 1% had neuro impairment, which is a pretty low number. So that means that they were doing these procedures quickly, and if they survived, they were not losing brain cells. Again, this was from the research from 1975 to 2020. Okay, so kind of an assessment of these outcomes. Does the effectiveness of the procedure outweigh the necessity for such an invasive surgery? The researchers determined that this was an extremely morbid procedure, meaning that this is like kind of last resort. Again, back to fetal care. This again would be for patients in extremis. Other things they noted were the costs of materials, having teams that could intervene quickly enough and with enough skill. It's such an intensive procedure cost-wise and personnel-wise that, again, you would have to have pretty much all hands on deck to make this procedure successful. They determined that blunt trauma patients have a lower chance of surviving this procedure, so you would have to assess blunt trauma more specifically than you would penetrating trauma. And the neurological outcomes, which were relatively good, all things considered, but still, you don't want patients losing brain cells. And that is it. Are there any questions? Savannah.
If this is an emergency procedure,
Yes, actually, one of my paramedics I worked with had he was learning how to do this in like the Badlands of New Mexico, for a flight response team. And they basically were teaching him how to take trauma shears. I don't know if you guys are familiar, basically scissors, and cut across and up the sternum and open it up and do an in-field cardiac massage, which has a very high chance of morbidity anyway. But if they're almost dead, so that was kind of the question there, Armando.
Are there any alternatives? Traumatic resuscitation?
Yeah, so there is one procedure. It's called a resuscitative endovascular balloon occlusion of the aorta. Basically, when I was talking about air embolisms, or no, this is for rather if you had any trauma to the large vessels, and they were bleeding out. This would be a slightly less invasive procedure in which you would fix the vessel by placing like a balloon in the lumen, and that would prevent it from continuing to bleed. So that could be a smaller alternative, but obviously doesn't solve issues like cardiac tamponade or air embolism, or cardiac arrest.
is it just like you would do the clamshell if you need like more access to the rest of the body, and that's the only thing?
Yeah, for example, another article I was looking at, that I didn't mention here, they had for patients who had like a penetrating injury on this side of the heart, it wasn't necessary for them to open the whole heart. So yeah, obviously, and then yeah, it's less traumatic for the body to heal from.
You showed the graphic of how like they decide whether or not to perform it. And I might have just missed it, but
I can go back to
how
it.
does age play a factor in that of the patient?
They didn't really assess that. It's not a super common procedure. And these tend to be trauma related procedures. So it's not like if you're like old cardiac patients, if you were assessing like CPR, for example, on older patients, that would be a more closed group. For these trauma patients, it's typically adults, but there's no specifics because anyone can be in a trauma related incident. It's not necessarily associated with your health. It's what happens to you just throughout the course. Does that answer your question?
Yeah, I was just thinking like if a child was in a car accident and like would they go to this procedure too?
Yeah, it wasn't typically for children. It wouldn't, especially because they're so tiny. It probably wouldn't survive to begin with the procedure, so it wouldn't be. Yeah, this would be more for adults. There was no specific information on that, but just knowing children wouldn't survive that kind of procedure anyway, this would probably be a more adult-focused procedure. Yeah, so kind of like I was saying earlier, the first incision on the lateral aspect of the chest, it's smaller. This would be more localized. Whereas if you were doing something that required more access to a greater part, that would be the open.
Did it affect like
Oh yeah, the second one is definitely more. It had a higher mortality rate, more traumatic. Any more questions?
No more questions? We still have a few minutes.
So what made you choose this topic?
I work in emergency medicine as an EMT, so anything related to this is super cool to me. I hope one day to not necessarily do this specifically, but be able to perform emergency procedures like this. So I just thought that was super cool because my paramedic was telling me how he was learning this in field. So I was curious, like in a hospital setting as opposed to a pre-hospital setting, like how that works. Because it's kind of, it sounded crazy to me. I didn't even think it was real at first, but yeah.
This has happened, this procedure,
Mhm.
does it occur more often in the pre-hospital setting like paramedics or more often?
It's historically began like the late 1800s. It was in pre-hospitally. Um, but obviously like most of the people that they did that on died. So it wasn't very effective. So typically this would like you'll see like EDRT, which is specifically Emergency Department Resuscitative Thoracotomy. So they're mostly performed now in like set surgical theaters. But they're bringing back, there's more of a push for pre-hospital setting procedures. But that's very like rural first response out in the middle of nowhere. That you won't see that like in city fire, for example, because you're usually pretty close to the hospital anyway.
So no other question, let me ask you the final question.
Okay.
So you showed they started the time period, this is almost 30 years, right? It's
Yeah.
a pretty long period.
Yeah.
And during this period, there's actually the skills and the equipment, the technology advances pretty quickly.
Yeah.
So then how can they actually evaluate the effectiveness of this kind of procedures? Considering, with regarding to the change of conditions like the technology skills.
Yeah. So this procedure has not changed a lot because I was wondering that too. The concept of the procedure, it's not complicated.
Mhm.
It's more about, can you do this quickly? And then because I listed like all the other things that you would need to do to follow up, you're not just opening the chest and leaving them there. That's not going to do anything. There are follow-up procedures that you do. So the determinant is oftentimes the rapidity of the procedures that you follow up with. But the procedure itself, emergency resuscitative thoracotomy, that hasn't really changed, which is
Mhm.
also why they're making it more appropriate for pre-hospital settings.
Right.
Because if it hasn't changed, it's more about is the provider doing it well? Is the provider doing follow-up care well as well? And then does the patient have a chance of surviving? Because again, if they were already kind of close to death or dead as it was, are they going to be able to come back from that, basically?
Okay,
Does that answer that?
yeah,
Okay.
thank you.
So if one of the more challenging aspects of this procedure is the patient's ability to recover post-procedure because it's so brutal, are they doing research on procedure treatment to see if they can recover at a faster rate, like putting them in a hyperbaric oxygen tank, which encourages wound healing and neural recovery? Are they doing anything like that?
Not specifically, again, for this procedure, that's a really good question. For this procedure, it's not very common, obviously, which is why they have such a large time span in which they observed it. There was a little bit about they assessed patients, and again, the number of patients that survive is already very low. And that's not just due to the procedure, that's also due to other comorbidities. They did do a small analysis of patients that were in SNFs, for example, skilled nursing facilities, or post-acute rehab centers. And they basically a lot of their numbers they drew from those patients who ended up outside the hospital. So that number was including patients who survived it and then also patients who got discharged following. So there's not a lot of, so I see your point, but because it's so few and far between, there's not any specific study done on it. So with another procedure, I'm sure you could like find a lot more information regarding it and it would have the same concept of what are we doing to care for these patients post-procedure.
Thank you. Let's thank Juicy again. Good job. And thank you all for the good questions.